My 12 years experience as a nurse, I have seen great suffering in patients and their families. I have seen patients go through agony, suffering, and even death. Ladies and gentlemen, my name is Lovelace Quarshie, a healthcare advocate for the elderly. Today, I would like to talk to you about my scholarly project, an evidence-based delirium program for managing delirium in hospitalized elderly that uses the Hospital Elder Life Program help guidelines and the confusion assessment method CAM tool. I would like to start by acknowledging my community members, Dr. West, Dr. Snow, and Dr. Adigan. Patients who suffer from delirium in a hospital have poor outcomes and quality of life. Delirium is an acute and often preventable medical condition characterized by disturbed thought process, shortened attention span, altered sleep-wake cycle, abrupt behavioral changes, and reduced environmental awareness. It begins abruptly and fluctuates over hours to days. Delirium may present in one or three ways: hyperactive, hyperactive, or mixed. Hyperactive delirium present may be anxious, agitated, delusional, combative, or disoriented, while hypoactive patient may be comatose, subdued, or lethargic. Hypoactive delirium goes unrecognized in the elderly due to the symptoms being attributed to illness. Mixed delirious patient will display symptoms from both types. The most common presentation. In all delirium, the patient will have altered awareness, disorganized speech, and impaired cognition and emotions. Delirium is a common syndrome characterized by the acute onset of altered mental status, hallmarked by difficulty sustaining attention and fluctuating costs, and frequently causing patients' family and healthcare providers considerable distress. Delirium can be caused by several factors, including infection, surgery, fever, electrolyte abnormalities, medications, and lack of adequate sleep, as well as equipment such as urinary catheter and restraints. The geriatric population is at increased rates for delirium. 40 to 60% of the hospitalized population experience some form of delirium. This increased risk is due to advanced age with hearing, visual, and urinary impairment, dementia, polypharmacy, medication side effect, and acute illness, which affect electrolyte balance and mental status. Delirium should be treated as a medical emergency. The bigger question is in geriatric population admitted to the acute care setting at risk for developing delirium, would the implementation of an evidence-based delirium assessment prevention and management program result in the reduction of episode of delirium, reduction of fall, reduction of functional decline, reduction in length of stay, improve in successful discharge to homes versus discharge to nursing home, and improve patient and family satisfaction? The purpose of this change in practice is to increase nursing knowledge and identify at-risk delirium patients, increase compliance in delirium screening utilizing the CAM tool, and help guidelines and improve patient safety. The project is significant to nursing because it showcases nurses' pivotal role in bridging the gap between evidence-based practice and clinical practice. In addition to lost wages, costs incurred to hospital-acquired delirium can be devastating. Statistics shows that about 60% of adults 65 years and older admitted to hospital develop some form of delirium. Untreated delirium costs about $16,303 to $64,421 per patient, implying that the national burden of delirium on healthcare system ranges from 38 billion to 152 billion each year. Delirium is a public health issue, and health systems and organizations must make resources available to ensure access to evidence-based care and improve patient outcome. This project allows the nurse leader to assume a leadership role in establishing new processes for practice. It also adds to the nurse leader expertise and promote recognition of the advanced practice nurse as a quality healthcare member of this patient population. This project was designed to facilitate the early identification of at-risk delirium patients in acute care setting, improve upon the associated challenges, and provide treatment. The patient received early intervention to reduce complications associated with delirium. There is a need for educational incentives and initiatives to enhance quality outcome. Providers should be informed of the various tools and protocols they can use to screen and manage delirium. The creation of policies and guidelines that requires training in the detection of delirium and policy that will allow consistency and standardization. The new process will allow providers to make patient evidence-based care decisions and increase staff involvement in evidence-based change. With a long-standing and still growing body of evidence pointing to significant health and financial impact of delirium on hospitalization and other healthcare costs, individuals at risk for delirium should be identified as quickly as possible, and preventative strategies should be implemented early in an encounter with the healthcare system. Affected individuals should be followed by discharge to mitigate a long-term effect of delirium after hospital discharge or other medical treatment. This will also make the organization a center of excellence and gain respect in the community and other healthcare organizations. A literature search was performed using the following database search to locate and analyze research studies on delirium assessment and management for at-risk patients with delirium. Research studies written in English and published between 2010 and 2022 were selected. Each of the research abstracts were reviewed for relevance for the topic chosen. Overall, the search generated 286 research articles and narrative 17 that were ultimately included in the literature review. The themes identified in this literature correlate with the importance of delirium identification, screening and management, using proper tools and protocols such as the Hospital Elder Life Program and the Confusion Assessment Method. Although delirium is observed in most patients admitted to the hospital medical surgical unit, finding shows that lack of knowledge and delirium identification resulting in less screening. A multidisciplinary approach to delirium management was also seen as an effective way to managing of at-risk patients. Several strategies were identified in the studies, including the several strengths were identified in the studies, including the study design, statistical analysis, discussions on finding, and adherence to ethical standards by seeking IRB approval. Weakness identified was the small sample size, lack of diversity. Most nurses usually work day shift who were involved in implementation. Patients, predominantly males, and the lack of discussion on social challenges were part of the barriers identified. Also, limitations in the studies include lack of training, resources, not knowing the sample size, and generalization. The gap identified that could be addressed were follow-up that after discharge to homes or nursing home and the outcome post-intervention, which would add to the body of evidence. An evidence-based delirium assessment, prevention, and management program for hospitalized elderly framed within the Carter and Cohen change model was utilized. Since this project is looking to change the current practice among nurses and providers, the change theory that seems to fit the project is the 8 steps in the Carter change model. Carter change model include urgency, team selection, vision, the strategy, communicating vision, empowerment, interim successes, ongoing persistence, and nourishment. The objective of this step will be to prepare the employees for the upcoming change and to motivate them to offer their contribution by changing thoughts, feelings, and attitudes. The first step is crucial, moving from the status quo to change in practice. For this step to succeed, roughly 75% of the organization's management should support the change initiative. All other stages are equally important to communicate, empower, and revise. The final stage is also essential to sustain the change and prevent staff from returning to the status quo by integrating it into normal way of doing things. This project utilized a quantitative exploratory design without participant engagement. A retrospective chart review was used for this project. Data collection utilized electronic medical record for the chosen unit. As with most DMP projects, a convenience sample was used to collect data. This evidence-based intervention was implemented in a 55 adult neurological stroke tele-event unit, where stroke protocols are implemented upon admission. The unit is equipped with vent room tele, various high technology tools and equipment. Also, there's a neurology team consisting of physicians and nurse practitioners and other nursing staff and supporting team members. The nurses on the unit have annual 4-hour education on stroke care. The NIH Stroke Knowledge and Information assists the nurse in recognizing signs and symptoms for stroke to ensure the diagnostic testing and treatment. The nurse to patient ratio is 5 to 1 instead of 4 to 1. A power analysis was used to determine that the project requires a sample of 154 participants. And since this is not an experimental project, there was no patient contact. Instead, neurocharts were reviewed for data collection. The practice site manager provided a list of patients who were seen on the unit during the pre and post implementation period. The project offers no direct benefit to the patient since this is a retrospective chart review. The project has very minimal risk, specifically breach of patient confidentiality. Efforts to secure data and reduce the risk include using data collection sheet and removing all identifiers, coding obstructed data to represent the ranges of the chosen variables. The data collection sheet was stored and locked on a password protected computer, providing 2 levels of security. The charts included in this project have documentation that the patient is 65 years and older, was admitted to the stroke unit and seen during the pre and post implementation data collection period. Chart and documentation of patient less than 65 years, history of dementia, fall in the past 6 months, or expired during the implementation period were automatically excluded from the data collection. All charts that did not meet this criteria were removed from the data collection pool. Data about the delirium screening, fall, length of stay, and discharge home were collected from the CAM and health protocol at the project site. The CAM tool was admitted at the first admission of the unit as the primary intervention to screen for at-risk delirium patients. Health protocols were activated for all positive patients identified with delirium. This project developed a data collection sheet to record the minimum necessary data to accomplish the goal without including any patient identifiers. Each chart was assigned a number to extract the data using numerical code to represent ranges of chosen variable and constitute the minimum necessary data to accomplish the project goal. Data collection stopped when the 154 charts were reviewed. After data collection, the reading list was returned to the practice manager for destruction. This is a sample of the CHEM and the health protocol for those who are not familiar with this tool. Here is a sample of the data collection sheet. The faculty supported included my chair, course instructor, and the Maryville statistician. Support from the project site included the director from the neuro department, all nurses and volunteers, neuro department physicians and clinicians, pharmacy and case managers, and other auxiliary team members that all provided support and guidance for this QI project. This program is very cost effective for the organization. The total cost of health program is $6,216. The program cost is recovered by decreasing fall rate, decreasing length of stay, and increasing patient and family satisfaction after orientation that would have not been achieved previously. Indirect financial gain are realized with increased nurse satisfaction, increased nurse retention, and improved community trust. The cost of one RN throughout orientation in a hospital unit costs the organization $20,000. If the organization cannot retain the nurse for at least 5 years, the organization loses money and increases the nurse to patient ratio. For this project, data was collected from two independent samples for data analysis, a pre and post intervention group. The data collected was in a yes and no format. Microsoft Excel spreadsheet SPSS was used for statistical analysis. Excel allowed for frequency and percentages to be calculated. Since the comparison between the rate before and after the intervention was desired, the z-test for the difference of two proportion, which is a directional form of chi-square, was used for statistical analysis. The overall finding of this scholarly project was a statistically significant increase in screening and management between the pre and post interventional group. Prior to this QI intervention, there were no screening for delirium in place at this hospital. Patients in the pre-interventional group did not get any screening at all at this first visit, leading to increased fall length of stay, discharges to nursing homes. The lack of screening led to increased fall rate of 5.9%, more than the targeted rate of 1.57%. Length of stay 4 to 6 days, more than the target of 2 days, and more discharges to nursing home. As seen in Figure 1, the interventional led to a drop in incidence of fall, decreased length of stay, and decreased the number of patients discharged to nursing homes. The z-test for the difference of two proportions revealed that the CAM tool and HELP intervention implemented in the neuro unit proved effective for prompt and adequate delirium symptom management provided to at-risk delirium patients presenting to the unit when compared to the patient treated for delirium before the intervention was implemented. There was a significant drop in the incidence of undiagnosed delirium for the implementation of CAM and HELP protocol, as evidenced by the decrease in signs and symptoms of delirium displayed in Figure 2. The overall finding of this scholarly project was a statistically significant increase in screening, management, and discharge home between the pre and post interventional group. The strength of this project include the use of relatively large sample size, the use of human translators when interacting with non-English speaking patients. Ethical standards were also followed, and the data collection sheet was also made this stronger. One of the project weaknesses is that a convenient sample is considered a weaker model compared to randomized or experimental design. Several assisted employees hired for the unit due to COVID did not receive interventional education. There is also the risk of biased interpretation of QI project and the short time frame for implementation, which may have skewed the findings. Facilitators include the support from staff and providers of the project site, case managers who are on site available to patients and family, and also easily accessible. Increased delirium awareness in the United States also facilitates patients and family eagerness to discuss delirium. For barriers, the ongoing pandemic, gap in communication between providers and other team members, and the high nurse to patient ratio caused some difficulties in care. The findings of this QI project suggest that elderly patients at risk for delirium are better served by providers when there is an early assessment for delirium using proper tools and protocols preventing delays in care and management prior to the intervention. Using the CAM tool and HELP protocol improved the early detection of delirium. The data suggests that patient outcomes were considerably improved when providers engaged in this early assessment for delirium. This study findings align with previous studies that highlights the value of CAM tool in improving detection of delirium during clinical care. These components were more critical in differentiating between delirium and dementia symptoms. The QI initiative prompted more consistent behavior among providers in their screening for delirium using CAM and HELP protocol, as well as their documentation. There is a need to investigate the long-term effectiveness of the CAM and HELP protocol in managing delirium. Future investigations should be more balanced pre-intervention and post-interventional samples to investigate if the project continued after the extended period, perhaps 1 year post-implementation. This intervention should be replicated in different settings and clinical units where all participants will receive the CAM tool and HELP protocol training to see if the outcome is consistent with interventional unit and to strengthen the research and verify results. follow up on patients that received the intervention post discharge to see also if there were benefit of early identification and management of delirium, which will benefit future research. The project allowed for early identification and intervention for at-risk delirium patients. The project initiative also addressed concern about variability among nurses and physicians by introducing standardized tools and protocol, clarifying the expectations of providers' next step and patients screened positive for delirium. The education that was offered to the staff and providers prior to the implementation of administering CAM tool and health protocol provided valuable discussion between providers and ensured that patients and families felt comfortable discussing their concern and was also supported to continue new process of administering CAM and help early intervention and also continue assessment of delirium throughout the hospital stay. With the reassuring finding of the benefit of early assessment of delirium in this unit, it is the hope that it will be the foundation for the development of healthcare policy that will reflect the best practice intended in the review of literature, as well as the project aim. The strategies introduced as part of the initiative, such as access to multidisciplinary running team for care coordination, help improve the quality of care patients receive. This QI project also addresses patient and provider level barriers by increasing provider confidence in delirium management. In conclusion, delirium is preventable, and having a tool that is easy to understand and use will increase compliance, improve nursing skill, and prevent delirium in the elderly. Tools such as CAM, which has been widely used, has been proven to be easy to use and also time efficient. Delirium is a severe issue in hospitalized elderly patients. Knowing the signs and symptoms, proper assessment and screening is the first step in preventing and treating identified at-risk patients. A standardized protocol will improve patient quality of care, improve patient and family satisfaction, decrease healthcare costs and waste, and increase nurse job satisfaction. This issue is vital to the increase in aging population living longer, who will be more susceptible to cognitive issues such as delirium. Nurse leaders have a significant role in educating and keeping nurses up to date on caring evidence-based practices. Their leadership role is also promoted and sustain the practice chain. This QI initiative shows that delirium is a significant problem for patients 65 years and older. Nurses play a vital role in patient quality improvement, and preventing delirium will positively impact these patients and their outcomes. This presentation is now open for questions you may have. Thank you. Please find attached references that were used for the support of this presentation. I would like to thank each and everyone for listening to my presentation, and thank you all for improving my knowledge and skills and helping me with my walk to freedom. Thank you once again.